focus of adhesions is indicated. Another common complaint we often hear is, "Doc, I must have hurt my knee getting out of my golf cart and it's not getting any better." This complaint is usually caused by a mild or major valgus mechanism of injury. Simply getting out of the driver's side of an automobile can injure this ligament. Younger individuals in active contact sports can frequently tear not only the MCL, but the ACL, the PCL, or either one of the menisci. I'd like to discuss the pathophysiology with you, and we'll move to the knee model here. You know the anatomy. We have the femur, the tibia, the patella, and the fibula, and the medial collateral ligament runs along the medial aspect of the knee from its femoral origin to its tibial insertion. This ligament is the one that is strained. I'd like to move to the physical exam. And when I examine the knee, I always examine both knees. I use the other knee as a control. With the patient seated on the exam table is the way I begin, palpating the femoral origin of the medial collateral ligament for tenderness. The mid-medial joint line will also be tender, occasionally the anterior medial joint line, and the tibial insertion of the medial collateral ligament. You will not usually see a lot of tenderness in the posterior medial joint line in a grade 1 or grade 2 sprain. Additionally, there will be some swelling of the knee. We also will see a loss of the end of extension of the knee and the loss of end flexion of the knee. It's always a good idea to test the stability of the knee, and we'll test the opening of the medial joint with the finger on the joint line in extension and in 30 degrees of flexion. More than a slight opening in extension could be indicative of a posterior cruciate ligament injury. It is a good idea to perform routine imaging studies, including AP and lateral knee x-rays, occasionally a sunrise patella view, as well as a weight-bearing x-ray, and occasionally, as indicated, an MRI scan. Treatment of medial collateral ligament injuries involves unloading the knee. We use crutches or a knee immobilizer, whichever the patient chooses. In addition, an anti-inflammatory medicine is helpful to relieve swelling and tenderness. Thirdly, a rehabilitation program involving strengthening of the quadriceps and restoring range of motion of the knee is also helpful. Usually, medial collateral ligament sprains will heal in 3 weeks, though some take 6 weeks. And in that younger individual that may have a multiply injured knee or a complete tear of the medial collateral ligament, close weekly follow-up of the stability of the knee is important, particularly in the early weeks. Another common complaint is, "Doc, I've been running for several years and now my knee hurts." This complaint is usually caused by a tear of the medial meniscal cartilage. Cartilages degenerate, as do other structures in the knee. Younger individuals will tear occasionally ligaments including the ACL and PCL in addition to the meniscal cartilages. In older individuals, the cartilage degenerates over time. In any event, they both present with medial or lateral knee pain, swelling in the knee, and loss of motion. The pathophysiology using the knee model, again, the tears are usually in the posterior medial horn of the medial meniscus here. 90% of the tears occur there, or in the posterior lateral horn of the lateral meniscus. 90% of the tears occur there. I'd like to go to the physical examination in medial meniscal tear. Again, it's a good idea to examine both knees. I use the opposite knee as a control, and patients will have tenderness over the posterior medial joint line of the knee in a medial meniscal tear, or over the posterior lateral joint line in a lateral meniscal tear. The collateral ligaments, the medial collateral ligament will be less tender, and the lateral collateral ligament will be less tender. They usually be a loss of extension of the knee, approximately 15 degrees. There will be some limitation of flexion of the knee, and in a few cases, the knee will actually be locked in flexion, and the patient will have to shake the knee in order to be able to extend the knee. We also need to do McMurray's test, and we palpate the posterior medial corner of the knee, and what we then do is externally rotate the lower leg. It'll usually produce some popping and pain. And then for the lateral McMurray's, again with our finger on the posterior lateral joint line, internally rotating the knee, producing similar symptoms. As always, it's a good idea to perform imaging studies in the knee, plain radiographs as we've mentioned earlier, but also occasionally an MRI scan is indicated. We like to see a grade 3 tear, which is a linear signal moving towards the joint surface on more than 2 cuts. Treatment of medial meniscal tears involves referral to an orthopedic surgeon for consideration of an arthroscopic partial medial meniscectomy or meniscal repair in a young, fresh tear involving the inner edge of the meniscus. These approaches should give you a good foundation on the latest treatment of these common problems. But what if your patient still has these complaints after 3 or 4 weeks? If that's the case, then you're probably dealing with a situation that calls for specialized treatment. Your patient with shoulder pain could have a partial rotator cuff tear or refractory adhesive capsulitis. The patient with knee sprain could have a partial medial meniscal tear, an osteochondral lesion, plica, or mild joint narrowing. In fact, there could be a variety of problems that your patient may be experiencing. That's when you might consider referring your patient to an orthopedist in the area. I would be happy to help you with these problems. I see them every week, if not every day, and they do require additional treatments. We've taken the opportunity to make it easy for you to get the specialized care your patient needs and you want. I've installed a dedicated telephone line that will not be given out to anyone except fellow physicians. When you call, this line will always be open. In fact, our employee, Ruby Parker here, will always be available to answer the phone. When you call, just give her the information. She'll make the appointment for you. After office hours, we will have the normal answering service available. Leave the information and the time you'll be available the next day, and Ms. Ruby Parker will call you. I hope this has been helpful. It should lead to happier patients and better treatment with a team approach. I look forward to working with you on those situations where you determine that your patient needs specialized care. If you want to discuss the details of any patient, please don't hesitate to give me a call. We will see your patient as soon as possible, hopefully the same day. Ruby Parker, what's that number again?
It's 254-9130.
Give me a call and I'll be happy to discuss it with you. Thanks. I look forward to hearing from you.